Okay, thanks, Dr. Orgemma. And we'll start off just, there was a typo in the pseudo-AS case that I showed you. Obviously, with the peak velocities going up, the TVI in the bottom went up, and this is the actual case. So just so you know, and correct that if you want to, not that important. So some of the questions that were asked, first with regards, there was a question on anticoagulation and mitral stenosis. So it's a class 1 indication to anticoagulate if you've had an embolic event or if you've had AFib, whether it be paroxysmal, persistent, or permanent. Interestingly, dilated left atrium in the setting of severe MS gets a class 2B indication. Although, quite honestly, if I saw a lot of smoke in a dilated LA in someone with severe MS, I would anticoagulate. Then there's two questions on dobutamine stress testing in AS, and one is why do we only go to 20 mics per kilogram per minute? That really is just what was done in the literature, and I think probably for fear of arrhythmia is why they didn't go up higher. I don't think in clinical practice it's necessarily wrong to go up higher. I would just probably do it in the cath lab where you're ready to resuscitate. But 20 mics in every single publication that's out there is the maximum. And then there was a question, how much should the AS gradient go up if it's trace or mild and it's a low EF and you give dobutamine? It shouldn't go up very much at all. So if it is really just trace or mild AS, very minimal increase in the gradient with dobutamine, even though flow will increase. Next, the question on is there an effect of blood pressure on mitral regurgitation? Absolutely. Definitely in functional. Definitely in prolapse, the degree of MR goes down when you come to the operating room. If you have a flail leaflet, probably it's not going to change too much. But for just prolapse and for functional MR, blood pressure definitely, it's very much a load-dependent parameter, and it will affect it, and that's why you should always report the blood pressure. So next, there was a whole bunch of questions on PISA and continuity and MR, and I'm just going to go through a second case here. This is pretty much similar to the case you have. You guys have my email. I'll be glad to send it to you. Give it to the people here if you want this particular case. But it's the same calculations, and just to go through it for the purposes of the boards, here's a 41-year-old woman with dyspnea on exertion. You can see the posterior leaflet here, quite abnormal, and the eccentric anteriorly directed jet of mitral regurgitation. It's a Mayo Clinic format, but nonetheless you can see the prolapse of the posterior leaflet. It's really probably partially flail. And we see a pretty significant eccentric jet of MR. Here's just a zoomed in view showing that it is flail. And now we can see actually a torn chordae right there. And in this case you can see that even though it's an eccentric jet, the PISA, the hemisphere, isn't really impinged on by the wall. So you don't have to do any of those extra calculations. So we freeze it, we zoom in on it, right at the peak of the T wave, right where you'll measure the peak velocity. And we measure the radius here at 1.1 centimeters with an aliasing velocity of 49. So we already know it's going to be severe. We then do the TVI and the peak velocity of the mitral regurgitation using CW. You should measure it at the same time that you measured your PISA. They should be at the same time. And you see the numbers here, peak velocity 570 centimeters per second, TVI 161. So now this is the boards, and you'll need to make this calculation. So we'll have an audience response. So let's go over the numbers again. Radius 1.1, aliasing velocity is 49, peak velocity 570 centimeters per second, TVI 161. So the first question is, what is the ERO? Yeah, so you noticed I gave you the units all the same, centimeters per second rather than meters per second, and that's important. All right, well, I'm glad we're going over it then, because it's pretty spread. It's maybe a teachable moment, but I think you'll definitely see these kind of calculations on the echo boards. You might even see it on the general cardiology boards, for that matter. And the correct answer here is 0.65 centimeters. So let's go through it. So the first thing we're going to do is calculate the flow. 2 pi r squared v. This is a formula you just need to remember. 2 pi r squared v. So 6.28 times 1.1 squared times the aliasing velocity, 49, gives us a flow of 372 cubic centimeters per second. So the first thing we do is calculate flow, 2 pi r squared v. The next thing we do, we can calculate the ERO directly by dividing by the peak velocity. Very important to have the same unit. So often we go 5 meters per second, but this is 570 centimeters per second. It's the peak velocity right there. And this gives us an ERO of 0.65, which is obviously in the severe range. 0.4 or higher for degenerative MR is severe. So the next step is, once we calculate the ERO, how do we calculate the regurgitant volume? So what is the regurgitant volume? And we'll have the audience response again here. Okay, well, a little bit spread out there again as well. And maybe it wasn't really fair because I didn't give you the numbers right in front of you. But 105 is right, and the majority were correct. But let's just go through it. Once we have the ERO, so we calculated flow, and we divided by the peak velocity to get that. We multiply by the TVI, which is, obviously the time velocity integral here, which is 161, and that gives us the flow. It's that simple with PISA. Now with and obviously you want to do correlative findings anytime you're dealing with MR. Here's systolic flow reversal in the pulmonary vein. But now continuity. So let's go through that with the same patient. So now flow. We need to know stroke volume here. And so to do that, we'll measure the LV outflow tract at 2.1 and the TVI of the LV outflow tract from an apical view. And here we got 20 centimeters. So to calculate stroke volume, you can use pi r squared or the diameter times 0.785, diameter squared times 0.785, and that gives us 69. So that's the stroke volume. We next measure the mitral annulus, and there was a question where you measure it. Really in diastole, at the same time you're measuring the forward flow with CW. So that's when we measure it. It's really a flawed measurement because of the complex shape of the mitral annulus, but nonetheless, we can now measure the mitral annular. So we got stroke volume, and now we need mitral valve stroke volume. And we can do the annulus. We're going to do this right at the annular level, not at the leaflet tips, with pulse Doppler. And we trace the modal velocity, and we got 16. So same thing we do here to calculate mitral valve stroke volume, 0.785 times the annulus squared times the TVI of 16, we got 191. Now we just calculate. So we know that the mitral valve stroke volume is the total minus this volume, which went forward. It has to then leave what's left, which is the blood that went backwards through the mitral valve. And in this case, it's 122 cubic centimeters or cc's. To get the regurgitant fraction, it's simply the mitral volume over the mitral stroke volume. And in this case, 64%, once again in the severe range. About 50% is severe. And finally, now you can back calculate the ERO using the continuity. The effective regurgitant orifice area equals the MR volume, which we calculated, the stroke volume. We took the stroke volume, the mitral stroke volume, minus the LV stroke volume, and that gave us the MR volume divided by the mitral regurgitation TVI, and that gives us a pretty big ERO as well. So we got 0.65 versus 0.76. Either way, it's pretty big. So this is an example of a type of calculation I think they'll ask you. So I would just be ready to do it. And I think once you understand the principles, it's not as hard. I'm glad to share this example with the meeting organizers. I'm happy to send it to you as well if you just send me an email.
I'd just like to make a comment. We'll be sure that this, as well as that equation file, gets to you, because I think these two examples are beautiful and would really help you with the ERO. The other point I'd like to make is vis-a-vis dobutamine. Remember, if you give too much dobutamine, it sort of defeats the purpose of what you're trying to achieve. You want to augment flow, and you want to get the VTI to rise. If you get too high a heart rate, the VTI will probably plateau because the heart rate is going to go up. So that's why there's a limit to either the amount of dobutamine you give, the way Sunil has mentioned, or looking for a 20% increase in the VTI in the left ventricular outflow tract, because you want to increase stroke volume. So that's why you don't give 40 mics of dobutamine, because you would get too high a heart rate response. Would you agree?
Yeah, and I think you can also provoke ischemia. A lot of these patients have coronary disease as well. All right, so let's get in. This is actually a fun talk to give. A few of the pictures will be a little repetitive of Dr. Lester's, but that'll drive home the point, I think. But I think that when they show you a systemic disease on the boards, once again, I think it's relatively low-hanging fruit, just like 3D echo. And I want you to do very well on this part of the test. And I have no disclosures. So, echo often doesn't make the diagnosis of the systemic disease, but it provides the first clue that there is something systemically going on, and then we do blood tests or a variety of other tests to make the diagnosis. There's autoimmune diseases, endocrine, collagen vascular disease, malignancy, amyloid or infiltrated, which Steve covered pretty well, radiation-induced heart disease, and the drug-induced valvulopathy. And we'll cover these and go over them in great detail. So we'll just do it in case format, an audience response. This is a 27-year-old female who presented with dyspnea, chest pain, and fatigue, class 3 symptoms. She had an abnormal nuclear stress test that led to coronary arteriography. The coronaries were normal, but the LV gram suggested, quote, hypertrophic cardiomyopathy with an EF of 75%. She had an elevated sedimentation rate, and she was referred to Mayo Clinic, and we performed an echo. So I'll let you look at the echo. Parasternal views here. This is an apical short axis. This is towards the apex. This is at the base. Okay, here are the apical views. I flipped them for you. So this is the right ventricle. This is the LV. This is more of an RV-centric view. Here's the diastolic data. We see a pretty short deceleration time, a very low E prime. E over E prime was 28. So high filling pressures, really a restrictive filling pattern. So what is the diagnosis? Is this hypertrophic cardiomyopathy, apical variant, amyloidosis, eosinophilic endomyocardial disease, LV noncompaction, or LV myxoma? Excellent. That's indeed correct. So you see, the systemic diseases, if you recognize it, I think that's something that the board, you'll just take it from them and you'll be happy. And this is indeed the case. The biopsy did show, eosinophils, shown here by the blue arrow. This is a disease, hypereosinophilic syndrome, a persistent increase in eosinophil count, usually more than 1,500. It develops heart failure. Usually a restrictive cardiomyopathy, but it can lead to mitral regurgitation, as I'll show you, and it can cause systemic embolization because you get superimposed thrombi. This is a beautiful review article that's in your syllabus. Whatever the process is that causes the eosinophilia, whether it be a malignancy, an allergic reaction, parasitic infection, autoimmune, or idiopathic, the eosinophils increase. That leads to then thrombus deposition and injury of the endothelium, degranulation of these eosinophils, tissue damage, then a necrotic phase happens, then a thrombotic phase, and then a fibrotic phase. Now, what are the 2D and echo Doppler findings? This is a review by Steve Amman. Restrictive diastolic filling and the classic obliteration of the apices, as you saw. This is a nice diagram by one of our sonographers, Leslie Elbert. And you see this deposition of these eosinophils and thrombi and fibrosis that occurs here, usually thrombus first, but then it progresses and it becomes more fibrotic. And this fibrosis extends up the lateral wall into the posterior mitral leaflet. And because it does that, it causes restricted movement of that posterior leaflet, and you get a characteristic mitral regurgitation. Here's a nice example of that from Dr. Pandian. He was kind enough to share it with me. So there's almost obliteration of the posterior leaflet right there. You see override of the anterior leaflet, and now we make the diagnosis of hypereosinophilic syndrome. Here it is once again. But note the fibrosis that extends all the way to the posterior leaflet. There's really not much of a posterior leaflet at all, and we see very severe mitral regurgitation. And you can see just how it extends into that posterior leaflet right there. So that's the characteristic type of MR that you'll get with this disease. Now, contrast can be helpful as well, as shown here. What the contrast does is just help you identify thrombi, because obviously there's no perfusion into thrombus. So the medical therapy is anti-inflammatory drugs, such as steroids. The differential did include all those things that I showed you in the initial question. And sometimes it can be tricky, and you need to use all these tools. But just keep that in mind and be able to differentiate these entities from this systemic disease. Our patient was treated with anticoagulation and a month of prednisone, and there was near resolution of all the abnormalities. A little bit still abnormal here in the RV apex, but for the most part, everything is better, and her diastolic parameters improved as well. Okay, what about other systemic diseases? Well, CREST syndrome is something to look at, and the key thing to remember there is pulmonary hypertension. So we screen patients with scleroderma and CREST for pulmonary hypertension. It's absolutely an appropriate indication to do an echo. And what we fear is severe pulmonary hypertension, where we see flattening of the interventricular septum, massive dilatation of the right heart, shown here. You can see the D-shaped left ventricle, small pericardial effusion, and we measure the TR velocity, and it's very high here. 53 plus the right atrial pressure would be her PA pressure. So pulmonary hypertension and CREST, know that relationship. It's present in 8 to 12% of patients with scleroderma. CREST is even higher than that. It accounts for 30% of the deaths. Screening for pH is recommended, and obviously the degree of pulmonary hypertension is important, but the cardiac index and other parameters of RV function are also important. Okay, what about other things that can have pericardial involvement? Well, in lupus, that's probably the most common reason to get a pericardial effusion with a systemic disease. 50 to 60% of patients with lupus will have a pericardial effusion. Less with rheumatoid arthritis, 10 to 30%. But if you see a pericardial effusion and no other explanation of it, we put it in our echo report, and then if they have other clinical parameters of lupus, it may help lead to the diagnosis, because 50 to 60% of patients with lupus will have some pericardial effusion. But what we fear with lupus are things like this. Libin-Sachs endocarditis or Morantic endocarditis. This was a patient with lupus, multiple strokes, and also had antiphospholipid antibody present, ANA positive. Here's a T view of the aortic valve. Notice the globular thickening vegetations. They turned out to be non-bacterial, but the globular nature of it, the diffuse nature of the thickening that we see there, is really the key. Once again, as Steve pointed out, we don't want to make a tissue diagnosis, but in the right setting and with these abnormal blood work parameters, we got to think about Morantic endocarditis. And this patient went to the OR and diagnosis was confirmed. Sometimes it can be more globular, though, and less diffuse. This is a case that you might be worried is a fibrolastoma. But once again, you do the echocardiogram, and then you get the blood work. And you see that this patient has a history of pericarditis and an ANA positive, lupus anticoagulant, anticardiolipin, antiphospholipid antibody positive. The blood work then helps establish the diagnosis, and in the right setting, then you think about Morantic or Libin-Sachs endocarditis, non-bacterial. So this is a zoomed-in view of the mitral valve by TE, and a very globular vegetation that's noted. It looks unusual for bacterial vegetation. Here's just the same patient, just different views. You can see it there. And you'd be worried about a fibrolastoma, but the blood work, I think, really leads you to the diagnosis. And that same patient with the mitral abnormality also had abnormalities of the aortic valve. So when you see a more diffuse situation where there's diffuse thickening. In this case, we would be hard-pressed to say there's a vegetation there, but we definitely would say it's a very abnormal aortic valve, and the patient was young. Quite a bit of aortic regurgitation was present. You can help make the diagnosis of Liebman-Sachs endocarditis. And that patient went to the OR and the diagnosis was confirmed. IgG, IgM, antiphospholipid antibodies. It's very unlikely to repair these valves. The choice of the prosthesis is very controversial. To be honest, some authorities recommend avoiding bioprostheses because the same thing that happened to the native valve can happen to the bioprosthesis. But by the same token, many of these patients are younger and still want to have children. So you're dealt with the complications of a mechanical valve in that setting and anticoagulation issues. So I think it's patient preference, to be truthful. And here's just a pathologic specimen from Dr. Edwards at Mayo. These are the blood work that can be abnormal in merantic endocarditis. Okay, audience response question. This is actually, believe it or not, this was a question that was on the ACC, one of their MOC things. A 68-year-old man presents with fatigue and abdominal bloating. On cardiac exam, jugular venous pressure reveals CV waves to the angle of the jaw. An RV lift is present. There's a grade 2/6 pansystolic murmur at the lower sternal border that gets louder with inspiration. There's a soft systolic ejection murmur at the second left intercostal space, and there's an enlarged and pulsatile liver. Here's his images, and hopefully they play. I don't think we leave it on my thing for now because I need to have the images play. Just not happy. I don't know, it's been programmed, but it might as well be this echo. Let's say it's the same patient. Take a look at it. So abdominal bloating, fatigue was his main symptom presentation. Flushing, weight loss is often seen. What's the diagnosis? We'll just move on. This is one that you really just got to recognize. And this is carcinoid syndrome, okay? The thickened, fixed, retracted leaflets of the right heart valves. Here's the tricuspid valve. You can see the leaflets thickened and fixed and retracted. The characteristic triangular cutoff Doppler signal because there's very severe tricuspid regurgitation. Characteristic echo findings are the thickening and retraction of the leaflets. They're fixed in a semi-open position. Remember, the pulmonic valve can also be involved, but keep in mind this cutoff sign here with very severe TR. I think you've already heard from numerous lectures, we cannot predict the PA systolic pressure in this setting because we don't know what the right atrial pressure is. There could be rapid equalization, and the right atrial pressure could be 50 in this setting. The right heart valves are involved, and the pulmonic valve can be involved too, both thickened and restricted movement. There's usually a mixed stenosis and regurgitation. So it's important to look at both the pulmonic and the tricuspid valve. Here's a short axis view of a pulmonic valve with carcinoid and a pathologic specimen that looks quite similar to it. It arises from the GI tract. It's slowly growing tumors, these carcinoid tumors. A variety of vasoactive substances are produced, but the one that's probably damaging to the valves is serotonin, and we measure HIA in the urine. The incidence is low, 1 to 2 per 100,000, and if you have carcinoid tumor, about a third of the time, 20 to 30%, you'll develop carcinoid syndrome. If you develop carcinoid syndrome, about half the time, you'll have cardiac valve involvement. There's a matrix-like deposition on the valves and the endocardial surface of the right side of the heart. It's important to note that treatment of the tumor does not cause regression of the valve disease. Unlike some of the diet drugs that cause valve disease, where you stop the drugs and there's significant regression, you don't see that in carcinoid. We've kind of gone over this, but most important, remember, right heart valves are the ones that are involved. Only in 10 to 15% of the times can you have left-sided involvement, and then you need an intracardiac shunt, primary bronchial carcinoid, or primary gonadal carcinoid that'll bypass the pulmonary circulation. And this is a beautiful example. I just couldn't resist showing 3D from a good friend, Denise Mararo in Italy. It looks just like this fixed photo. Thickening, this is an en face view from the RV perspective, and you can see just the thickening and retraction and fixed nature of the leaflets. It could be one of the 3Ds they show you, though. That's why I wanted to show it. So you produce these substances. It causes symptoms of flushing, wheezing, diarrhea. 50% of the people that have the syndrome will have cardiac involvement. 20 to 30% of people with carcinoid tumors will get carcinoid syndrome. And this is a nice diagram Dr. Connolly put together where you have these tumor mets in the liver. They produce these substances. They cause the injury. Serotonin probably is very much involved to the right-sided valves in the endocardium. It gets filtered out by the lungs and doesn't return to the left side of the heart, so it's rare that you'll get left-sided heart lesions unless there's an intracardiac shunt or some other strange situation. Now, it's important to note just in clinical practice that if patients are very symptomatic from their valvular heart disease, class 3 or 4 symptoms, dilated heart, quite a bit of edema, you can improve the quality of their life with surgery. And Dr. Connolly and Pellick at our institution showed that. And, symptomatic disease, you try to control the tumor and suppress it. Work with your oncologists and GI doctors so that it's suppressed as much as possible. But then we usually fix the heart valves before they try to resect the tumors in the liver. And then patients actually do pretty well. Their symptoms definitely get better. And just to show you a TE view of a tricuspid valve, in case they show that to you, here's a dilated heart, the thickened, retracted, fixed leaflets, severe TR, as you show here, and a 3D of it en face, side by side with a 2D. So this is from the RV perspective, right there. The leaflets are thickened and fixed and open. And don't forget to look for the tumor mets whenever you do a TE on these patients. If you can see them, and here's just a picture of the liver, that you can see. All right, next systemic disease. This is a 58-year-old man with pulmonary infiltrates and syncope. Pulmonary infiltrates and syncope. His EKG shows conduction abnormality. A conduction abnormality. Here's his echo. So we see it's a dilated heart. We see regional abnormalities, but they're unusual regional abnormalities. We see kind of almost an aneurysm here, but it's a very unusual regional distribution. This is cardiac sarcoidosis. So it's caused by non-caseating granulomas. Obviously, they'll present a patient with pulmonary issues, and usually they'll have some conduction abnormality of the heart. And then you see regional abnormalities that are not in the distribution of the coronary territory. Basal aneurysms, the septum, the lateral wall can occur. Heart block and sudden death can occur. These are just the areas that are affected the most, the interventricular septum and the left ventricular free wall. And it won't really be in the distribution of a coronary territory. Now, although echo abnormalities in sarcoid is rare, if you do see it, it can help lead to the diagnosis and certainly can add to it. But all of these things that do occur are actually pretty rare. So oftentimes in patients with sarcoid, you'll see no abnormality by echocardiography. Whereas with MRI, a more sensitive technique, you probably could pick it up a little bit sooner. Okay, another systemic disease. This was a 58-year-old woman with weight loss, tremor, and a heart rate of 125 beats per minute. And she has a dilated cardiomyopathy. Here's the left ventricle, AFib with a rapid rate, tremor, weight loss, hyperthyroidism. So, obviously they can present with AFib. It can be tough to control the rate. That should be a clue that they might have hyperthyroidism. They can be hypotensive, and part of the LV dysfunction is not necessarily from the endocrine abnormality, it's just the tachycardia, a tachycardia-induced cardiomyopathy that develops. And many patients are unaware that they're going tachycardic and unaware of their rhythm. And lo and behold, our patient, after cardioversion treatment of her hyperthyroidism, LV function became normal. Just look at the cardiac silhouette initially, and then after treatment of her hyperthyroidism. So AFib with a rapid rate, tachycardia-induced cardiomyopathy. The opposite is hypothyroidism. They can have a little bit of a cardiomyopathy or a large pleural pericardial effusion, as in this case. This is a patient with profound hypothyroidism. So both ends of the spectrum, I think, are important to note. All right, now this next section is just a little bit of review, but I think important because I definitely think you'll see these on the boards. A 43-year-old man, EKG with low voltage. Low voltage. Sure enough, here's his echo. Classic cardiac amyloidosis. The key thing is here, thickening of the heart. Remember, it's not myocyte hypertrophy, though. It's interstitial thickening. There's a pericardial effusion and a pleural effusion that you can see here as well. Look at the thickening of the leaflets as well. That's an important clue. Really thickened leaflets. And then don't forget to look at the interatrial septum. It has a characteristic thickening in amyloidosis. Dr. Feigenbaum, I once heard him say he's never seen a case of amyloid without thickening of the interatrial septum. It's not the dumbbell thickening that you get with lipomatous hypertrophy either. But as Steve pointed out, and I'm actually not going to do an audience response because Steve taught him too well, there's a differential diagnosis of a thickened heart, okay? 19-year-old male with an abnormal gait, so neurologic abnormalities, and the heart's thick. This is indeed Friedreich's ataxia. So there's a differential when you have a thick wall. And this will be a little bit of review, but it's important to go through. And this is a neurologic disorder. I think that's all you really need to know for the echo boards. You see a thick heart in a young person, he can't walk and he's got neurologic issues, it's probably Friedreich's ataxia. The important thing, though, is there's an absence of SAM and prominent papillary muscles. That can help. So these are all mimickers of amyloid, and they're listed in your syllabus. And you need to be able to differentiate it. And the truth is you can't sometimes by echo. So keep that in mind. I think the board is going to stick pretty much with amyloid, but they'll want you to know that there's a differential. Here's hyperoxaluria. Steve showed you a different case, but remember this was the heart of bone. I like that term, Steve. Okay. But I mean, it looks like a thickened infiltrative cardiomyopathy for all the world. Fabry's disease, that Steve also showed you. The key is it's treatable. It's treatable. It's a reversible cardiomyopathy, and that's important to note. Now, the Italians have reported this binary appearance where the endocardium is very bright and the epicardium is very bright, but the mid-myocardium is less bright. So this binary appearance is something that has been reported on specific to Fabry's disease. I don't know that we think that it's quite as robust as the Italians, but here's their paper, and they found that it was very sensitive and specific for separating out amyloid or other infiltrative cardiomyopathies. So the endocardium being bright and the epicardium being bright. They had pretty good numbers, as you can see here, 94% and 100% for sensitivity and specificity. But we've seen it in amyloid as well, quite honestly. This is hydroxychloroquine-induced cardiotoxicity, a chemotherapy agent. It once again looks like an infiltrative cardiomyopathy. It can look like amyloid. You know, the valves aren't quite as thick. That could be a clue. And don't forget to look at the atrial septum. See how it thins out here? That's unlikely to be amyloid in that case. But there are mimickers. That's the important thing. And probably this is the most common thing we see that looks like amyloid, renal failure. I mean, it looks like an acoustic speckled kind of pattern that we see. In the newer echo machines, we see this all the time. This patient just had renal failure. If you want to read a great review about these mimickers, Dr. Seward from our institution published this paper, and it's in your references. The important thing, though, is there's a differentiation. All right, this is something you absolutely need to recognize for the boards. This is a 56-year-old woman with a history of radiation therapy for Hodgkin's. And what do we see here? Well, we see calcification of the aortic valve, thickening with restricted mobility. We see mitral annular calcification, but in a specific pattern. It's the anterior mitral annulus that's very calcified. Normally, we see it's the posterior mitral annulus that becomes more calcified. But in this case, it's the anterior mitral annulus. When you see anterior mitral annular calcification, you should really rule out radiation-induced heart disease until proven otherwise. And of course, when you see aortic stenosis, that really helps you make the diagnosis too, that this is the case. And then you find the history that the patient had mantle radiation, then of course you know. Early on with radiation, you can get a pericarditis. Then it can also cause some degree of a restrictive cardiomyopathy. Of course, we've all seen it cause coronary disease and then conduction system defects as well. Things that are important in determining whether you get it is the total radiation dose, getting it at a younger age, a higher percentage of anterior-posterior radiation, and if you had coexistent chemotherapy with anthracyclines, that puts you at higher risk. And certain other cardiovascular risk factors also increase the incidence of radiation-induced heart disease. When do you get it? Well, the coronary disease occurs about 10 years, 9 or 10 years after the radiation, so pretty early on, 9 or 10 years. Whereas the valve disease can present, decades later, 22 years later in this series. So a decade later, really, then you get the coronary disease. Usually, you get aortic stenosis and mitral regurgitation. But keep in mind that image of anterior mitral annular calcification and thickening. Very few things will cause that. And if you have coexistent aortic stenosis, it's a pretty good bet it's radiation-induced heart disease. And that's a very tough thing to treat. Finally, let's close with the drug-induced valvular issues. Thickening and retraction of the leaflets. There's no commissural fusion, but other than that, it looks a lot like rheumatic valve disease. Thickening, fused, shortened chordal apparatus, variable regurgitation, but rarely leads to stenosis, more regurgitation. But if you don't see the commissures, you can easily mistake it for rheumatic valve disease. And here's a classic example of ergot-induced valve disease. Patients that have had migraine headaches. We'll let it play through a couple times. There's aortic regurgitation, thickening of the aortic valve. Look at the doming that's occurring there. It looks like almost rheumatic of the mitral. In this case, the tricuspid's involved. A little bit of the pulmonic, but not so much. I'm going to let that play through, and you can see it's left-sided involvement, thickening, doming of the leaflets, and I'll let that play through once again. In this case, there's mixed stenosis and regurg, but regurgitation is more common. Mitral gradient was 10, systolic reversal in the hepatic veins from severe TR. And I'm going to let this play one more time because I want you to see right here the mitral valve. Look at that. I think that can be really helpful to make the diagnosis. It looks like rheumatic. It looks like rheumatic. I'm just going to play that little segment again right there. That's what you want to keep in mind. Now, many drugs can cause this. Ergots, of course, are very common. Migraine headache drugs. Obviously, fen-phen, but we don't see that too much anymore. Pergolide, cabergoline. Ecstasy is a drug of abuse, MDMA, that can look at this, and apparently it's still increasing in the younger population, which is sad to hear. But they all seem to affect this receptor, this 5-HT receptor, causing a pro-inflammatory response that mimics and looks like a rheumatic situation, except there's no fusion of the commissures. But there's doming of the leaflets, thickening of the leaflets, and many drugs can cause it. If you stop the drug, generally there is reversal of the valvular abnormality. And this is just to deal with ecstasy. It's apparently still very common and pretty scary to think that kids are using it still. And it can lead to valvulopathy in a young patient that'll look a lot like rheumatic. Okay, I think this is the last case. This is a 60-year-old male farmer. He's referred for evaluation of dyspnea, diabetes mellitus, and abnormal LFTs. You probably know the diagnosis already. Blood pressure is 110/70, heart rate 70. He's got a gallop, an S3 gallop, and bronze skin. Diabetes, abnormal LFTs, bronze skin. Here's a ZKG. It's a left bundle branch block. Chest X-ray shows a little cardiomegaly. And the echo shows a dilated cardiomyopathy with reduced ejection fraction, globally reduced. Here's some apical views, apical short axis, and two-chamber view. Fairly global, but I think you'll agree severe systolic dysfunction or severely reduced EF. He had normal, not normal, but minimal coronary artery disease. Certainly nothing to explain the degree of LV dysfunction that he has. There is probably mild to moderate disease, but nothing to explain global cardiomyopathy. And just show you some other shots here. I'm not hiding anything from you this time. Okay, so let's find out first, what should we do next? Would you recommend biopsy? Sorry. Cardiac MRI, CT, or dobutamine stress echo? All right, excellent, excellent. Very astute audience here, Dr. Urajama. So MRI can be good for a couple of reasons, okay? First of all, you can do all the same things you can get with the echo as far as ejection fraction. And in this case, you can see the global cardiomyopathy in a tomographic kind of pattern. We can do that with echo too by 3D and contrast. So nonetheless, though, MRI is very good to assess EF. But in addition, you can also get other things with MRI. In this case, there's no delayed hyperenhancement. So there's no scar, which can point you in one direction or another, help you make the diagnosis perhaps of myocarditis. So this is a 60-year-old farmer with type 2 diabetes, bronze skin, and abnormal LFTs. What do you think is the most likely diagnosis? Is it hemochromatosis, amyloidosis, sarcoidosis, Fabry's, or carcinoid? Dilated cardiomyopathy with the history as noted above. I was really hoping for 100. Wait a minute. It doesn't add up to 100. There's no other 1%. Nah. Well, of course, as you all know in the audience, and the reason you order the MRI is there's something else that you can get with the MRI. But nonetheless, this is hemochromatosis. Increase in total body iron, deposits in the heart, liver, and other organs as well. It's an iron overload cardiomyopathy. This is a beautiful review that I put in your syllabus. There's different characteristics. You know, I don't know if I'll ever remember these, but there's different types of hemochromatosis. The important thing is it's treatable. Now, it usually presents directly with a dilated cardiomyopathy, but you may detect it earlier, and it can present with a more restrictive cardiomyopathy, so keep that in mind. But think of this when you see a dilated cardiomyopathy in the setting of hepatic dysfunction, diabetes, and tan skin. This patient has a severe cardiomyopathy. Iron is directly toxic to the myocytes. It is a reversible cardiomyopathy. Male predominance 9-1. Ferritin is usually very high. There's other iron tests that you can get as well. Usually normal wall thickness. There could be conduction abnormalities, as in our patient, and arrhythmias. Here's a young patient I took care of in the CCU, 26-year-old. And this is the Mayo Clinic format, so this is the left ventricle. Actually presented with an embolic event and had thrombus here in his left ventricular apex. Look at this severe LV dysfunction and very impressive thrombus. But we treated him. His heart normalized. He made a complete recovery. So making the diagnosis is really crucial. And with MRI, you probably don't need to do a biopsy anymore, okay? Not of this disease, because T2 sequencing can be done. And so I did hold something back from you. If you ordered the MRI as you all wanted, you would have made the diagnosis, because they look at the region of interest in the myocardium and also in the liver, and they apparently can do this T2 relaxation time and evaluate the degree of iron overload, and it basically is a way to help establish the diagnosis, but also monitor treatment and how much chelation therapy you give, so to speak. So our patient was given deferoxamine and made a real complete recovery. Remember, the iron heart is a weak heart. Hemochromatosis may be a cause of an idiopathic dilated cardiomyopathy. It's reversible with treatment. And cardiac MRI is very important to establish the diagnosis. And just a couple other reviews in your syllabus, how it can be, MRI can be used to monitor treatment from Dudley Pinnell and a group of MRI experts. I guess I did have this case here. This is just a 28-year-old male with hemophilia and dyspnea. And this is a patient with HIV. HIV can present with a cardiomyopathy as well as a pericardial effusion. Patients can also develop pulmonary hypertension, although it's not sure if maybe it was the drug use and something in the heroin that caused the pulmonary hypertension. But HIV and cardiac disease is something to think about. With the treatment for HIV nowadays, we're seeing this less and less. But you can have myocarditis, you can have a dilated cardiomyopathy, pericarditis, and effusions. So I'll conclude. This is a complete list of the things you need to recognize on echo, I think, for systemic diseases. Carcinoid syndrome, I think 100% of you will get that. Hypereosinophilic syndrome, close to 100%. Sarcoidosis, that's tougher, but look for regional abnormalities not in a typical distribution of coronary disease. And they'll have lung disease and usually some conduction abnormality. Lupus, most commonly effusion, but if they have lupus anticoagulant or antiphospholipid antibody, they can get marantic endocarditis. For CREST, think pulmonary hypertension. Dr. Lester showed you amyloidosis, and the mimickers are really tough to know. Hypothyroidism, radiation heart disease, anterior mitral annular calcification, drug-induced valve disease, mimics rheumatic disease, and hemochromatosis. So I'll stop with a video. If we have sound, I want to wish you good luck on the exam.
1 minute. 1 minute, please. Time, thank you. Could you all please put down your pens and bring your papers to the front of the room? Thank you. Well done. Thank you. Thank you. Thank you. Oh, I'm sorry, you're too late. Gave you plenty of warnings about time. You failed. Sorry.
Excuse me, do you know who I am?
I have absolutely no idea.
Good.
Dr. Mancott is not recommending that you try that on the exam. Should I just, I'm on number 4, should I just hit the button? So, given that we have a couple minutes, I want to just present a couple things because there's a question that keeps coming up that I figure hopefully we can dispense with this. And then Dr. Lester has some slides that he wants to show that bear on the issue of bicuspid valves and aortic regurgitation. So just to show you that, just click on this. Okay, good. So this is the file. I just handed this in to Brandy. Dennis Teig and myself and Ravin, but mostly Dennis, made this up a few years ago, and it's got a whole bunch of the equations and a couple of case examples. So Brandy has that, and she's going to upload that. So hopefully that will help you with the question issues, the calculation issues. The second thing is I do want to spend 1 minute going over this concept because there have been a number of questions about this. So this is clearly something you have to know how to do, namely to calculate a stroke volume from the data that they will give you. This will play a role in a lot of the different equations. So just to reiterate, this has already been discussed, but just to go over it one more time, and this is in the equation slide deck that I gave to Brandy. Flow is equal plug flow is equal to cross-sectional area times the velocity time integral. You obtain the cross-sectional area, you have to know the radius. So for any calculation questions on stroke volume or cardiac output, they will give you the left ventricular outflow tract diameter, and most of the time that's going to be 2 centimeters because it makes the radius 1, and then plugging that into the equation, it'll just be pi times the radius squared, which will end up being pi if the diameter is 2 centimeters, which it usually is in these calculation questions, okay? But I think here's the thing that I think I mentioned in my lecture, and then I think someone else did, talking about this famous modal velocity. So I just want to spend a second going over this modal velocity. Here's an example of a forward stroke volume calculation from our laboratory. You want to get the aortic valve open. You want to stop this in mid-systole, and I'm going to show you a slide on how to make that measurement. And then you want to trace the velocity time integral from the left ventricular outflow tract systolic signal. Now, I think it's on the, here's your measurement of the outflow tract, and this is in the valve, this figure is taken out of the valve stenosis guidelines, so you should be able to come up with this. And so they actually show you, and they recommend measuring your outflow tract diameter, again, mid-systole, the valve leaflets should be open, and they recommend in the guidelines going from 0.5 to 1 centimeter apical to the insertion of the aortic valve leaflets, okay? So this is the type of measurement. It's not the same as the annulus dimension, okay? Now, people do talk about, and Rebecca Hahn, I think, is a proponent of using, for her TAVI cases, of using the annular dimension for the calculation of stroke volume. But according to the ASE quantitation guidelines and the stenosis guidelines, you want to measure the outflow tract in mid-systole anywhere from 0.5 to 1 centimeter proximal to the valve, okay? It is not the same as the annular dimension. So that's one part of the stroke volume equation, and here's the second part. This, again, from the guidelines, shows you a typical left ventricular outflow tract signal. As I mentioned in some of the questionnaires to some of the people who came up afterwards, the modal velocity is the bright line, which is where most of the red cells are located in this spectral profile. The guidelines recommend tracing just outside of this bright line to get your velocity time integral, okay? So by modal velocity, it's just a statistical term, meaning that's where most of the red cells are located. And the typical red cell at any given time is going to be located, that's traveling through the outflow tract, is going to be located somewhere in this band of velocities. So you want to go outside, just slightly outside of this to trace your left ventricular outflow tract velocity time integral. And as I think it was Sunil who said, you want to give that profile a little bit of a haircut. You don't want to be tracing the sort of whisker or feathery lines that one might see. So is that clear about the modal velocity now? Are we okay with that? I would not call that an overwhelming consensus. I'd recommend that you go back and look at the quantitation guidelines and the valve stenosis guidelines, and you'll see this figure. And so I don't think you'll get a question on modal velocity. No one's going to ask you that. But just for your own practice, this is how it is recommended that you make this measurement. And I just want to show you an example of where it pays to pay attention to the velocity time integral in left ventricular outflow tract. This is from the study of a patient who just came through our lab a few weeks ago. This is a woman where we did not have much of a history. We knew she had immigrated to the U.S., and she has a sizable left ventricle, and we actually have some dimension data. We did biplane method of discs and looked at her left ventricular volume, both in diastole and systole. We indexed her left ventricular volume in diastole and compared it to the most recent guidelines. These are the quantitation guidelines, which we don't think you're going to be tested on, but again, for clinical practice, just to see whether or not this heart is actually big. And in fact, her left ventricular volume in diastole indexed to body surface area did end up being bigger than the normal limits that were reported. So it's a big heart with normal function, and we were kind of puzzled as to why this person had such a big heart. She certainly had good systolic function. And this is where I think having a velocity time integral is quite helpful. So in our lab, at least in my practice, I look at the velocity time integral number. I actually have a feel for what the normal range would be, and it's usually somewhere between 18 and 21 centimeters in patients who are normal at a normal heart rate. Obviously, with severe tachycardia, the amount of flow that goes through the aortic valve per beat with severe tachycardia is going to be reduced. And certainly any condition that reduces stroke volume, myocardial pathology, is going to lead to a lower stroke volume and a lower VTI. But this person had a rather large VTI, 29.6, and when we actually measured when we actually did a little bit more Doppler, we found that, in fact, she had a very large patent ductus arteriosus that was kind of nailed by this spectral Doppler profile. So this is an example of if you're going through and you see somebody at a normal heart rate with a VTI that is almost 30, you should be thinking about some type of high output state on the left side. Typically anemia, somebody with AV fistula, pregnancy, and also end-stage liver disease. These are all conditions that show up very commonly in echo labs where the VTI is going to be quite high and the cardiac output is going to be high. So I thought maybe that would help a bit in trying to help you understand the stroke volume calculation. No, go ahead. Do at least one of them. Yeah.
Okay. All right. I'll slip with you. Just take 2 secs. I thought we would have time because there's all these questions on aortic sclerosis and bicuspid aortic valve. So I thought I'd just take 3 minutes, and then we'll get some tea. Then we'll talk about stress echo and look at some cases. So the rest of the afternoon should be pretty relaxing. This is just the cardiovascular health study. In yellow, you see individuals with normal. Pink is aortic sclerosis, and green is aortic stenosis. This won't be in the syllabus, of course. But the point of this is that, of course, aortic sclerosis is not a benign condition. The presence of aortic sclerosis, in fact, does portend adverse prognostic significance in terms of all-cause mortality, cardiovascular death, myocardial infarction, stroke, and so forth. So what is the definition of aortic sclerosis? I'm not sure if that comes up in the next couple of slides because this was discussed yesterday. Really, the definition of aortic sclerosis is focal thickening of the aortic valve without restriction to cusp motion. And the new guidelines suggest a peak transaortic velocity will be less than 2 meters per second. It used to be 2.5, and now it's 2 meters per second. But it's focal thickening without restriction to cusp motion. If an individual has aortic sclerosis, what's the likelihood they're going to progress to aortic stenosis? Pretty small, about 10% in 5 years. And if you look at the degree of stenosis, the majority of them will continue to have mild aortic stenosis. So although it's a small percentage of individuals, given the frequency or prevalence of aortic sclerosis, it represents a high number of potential individuals. So this is a picture of an individual with aortic sclerosis. This focal thickening of the valve, these would be in the new guidelines, stage A disease, patients with the risk factors for the development of AS. On the right, we see bicuspid aortic valve. And in bicuspid aortic valves, the majority of them will be asymmetrical, meaning that the fused cusps, as we'll see here, may incorporate more than 100 degrees of the circumference of the annulus. This we see there's fusion of the right and the left cusp in this particular patient. So here what we see is, this was what had been asked a few times, the bicuspid valve phenotypes. Most commonly, you're going to see fusion of the right and the left cusps. This is what we see here down below, fusion of the right and the left cusps. The next most common would be fusion of the right and the non-coronary cusp, which I believe is here. So here we see fusion, and so it's about 70-30. Rarely do you see fusion of the non-coronary cusp in the left. So I don't think they'll ask you this question per se, but it was brought up a couple of times yesterday. So most common is right-left fusion, and then your next most common would be right non-coronary fusion. It's about maybe 5% or though are they completely symmetrical, where each of the cusps here represents about 180 degrees of the circumference. This is a true bicuspid valve because there's no raphe. You can see individuals that have partial fusion of one of the cusps, as we see here. So it's all like partial fusion of the right-left cusp. The issue, of course, is that this isn't just a valvular disease, it's a valvular aortopathy. These individuals have decreased fibrillin, and elastin fragments, they have apoptosis, and it results in smooth muscle cell detachment, matrix deposition, cell death, and these individuals are at risk for dilation of the ascending aorta. For whatever it's worth, if you see dilation of the tubular portion of the ascending aorta, that is a little bit more common in the less frequent morphologic form, which is the right non-coronary bicuspid valve. In individuals where you see just dilation of the root, this is more common in the most common form, which is the right-left. If for whatever, people have asked that a few times. So that is the answer to the question that it had. So if you see this pattern C, that this fusion of left-right would be more common. Just to remember that bicuspid aortic valve can be associated with coarctation of the aorta. This is a really nice signal because what you see is the continuous forward flow through diastole. That's sort of the hallmark of aortic coarctation. There remains a gradient between the proximal and distal portion of the obstruction throughout diastole. So this pattern of continued flow would be suggestive of coarctation. 10% of bicuspid valves have coarctation. About 40 to 50% of coarcs have a bicuspid aortic valve. And that's all I really wanted to say about this, because I think we go for a break now, right?